Dr. Vaishnavi K. Adappa.
Okay, thank you, sir.
Okay. Beyond the birthmark, the silent threat of glaucoma in Sturge-Weber syndrome.
Good evening. My presentation is on the silent threat of glaucoma in Sturge-Weber syndrome. I'll be presenting a case report of Sturge-Weber syndrome with secondary open-angle glaucoma. So Sturge-Weber syndrome is also known as encephalophacial or encephalotrigeminal hemangiomatosis. It's a neurooculocutaneous syndrome with congenital hematomas involving the eye, skin and the brain, characterized by the presence of choroidal, episcleral or conjunctival hemangiomas, presence of portwine staining in the skin, and presence of leptomeningeal hemangiomas in the brain. The glaucoma in Sturge-Weber syndrome occurs due to either anterior chamber angle malformation or elevated episcleral venous pressure. So a 7-year-old girl with Sturge-Weber syndrome was referred by the pediatrician for detailed ophthalmological evaluation. She had portwine colored lesion in the right upper part of the face since birth, and there was history of one episode of seizures in the past. There was no family history of any neurocutaneous disease. This picture shows the presence of portwine colored stain or nevus flammeus in the right upper part of the face, which was present since birth. Non-contrast CT of the patient showed multiple dense areas of calcifications causing volume loss along the cortical and the subcortical regions of right temporoparietal occipital lobes, causing tram track sign. On examination, the visual acuity was 6/60 in the right eye and 6/12 in the left eye. Anterior segment evaluation showed bluish discoloration of the conjunctiva and episclera bilaterally, and intraocular pressure in the right eye was 29 millimeters of mercury, and in the left eye, IOP was 15 millimeters of mercury, which was measured with eye care. Gonioscopy showed open angles in both the eyes. Fundoscopy done showed a cup disc ratio of 0.8 in the right eye with bipolar neuroretinal rim thinning, and in the left eye the cup disc ratio was 0.5 with intact neuroretinal rim. Background retina was normal in both eyes. So the patient was diagnosed as Sturge-Weber syndrome with right eye secondary open angle glaucoma, and for management the patient was started on dorzolamide eye drops for the right eye, and right eye trabeculectomy under guarded visual prognosis was advised. Discussion: around 30 to 70% of patients with Sturge-Weber syndrome present with glaucoma, out of which 60% of these patients present at birth who have congenital glaucoma, and the rest 40% manifest glaucoma later in life. The cause for congenital glaucoma in Sturge-Weber's is thought to be due to anterior angle chamber malformations, which can be due to widened uveal meshwork or anterior insertion of the root of iris or direct insertion of the ciliary muscle into the trabecular meshwork. And the late onset glaucoma in Sturge-Weber's is thought to be elevated episcleral venous pressure, and in some cases due to premature aging of the trabecular meshwork. Increased incidence of glaucoma is seen in cases of portwine staining involving the upper eyelid, and also portwine staining involving both the sides of the face. It has also been seen that the glaucoma incidence is more in patients who have both V1 and first and second dermatome of trigeminal nerve involved. So concluding, this case report highlights the importance of early detection of glaucoma and multidisciplinary approach in the management of patients with Sturge-Weber syndrome. It also signifies the need for addressing both the ophthalmological as well as the systemic aspects of this condition in order to provide the best possible outcome for the patient. Thank you.
So, what was the age of the patient?
7-year-old, ma'am.
7-year-old child. Okay. So, was it a bilateral or was it a unilateral phenomenon?
Ma'am, the portwine staining was bilateral, ma'am. But the intraocular features, there was only melanosis in the conjunctiva and the episclera bilaterally, but the IOP was higher only in the right eye, and even CNS findings were unilateral, ma'am, only right-sided.
Okay. So, what was the cause of this glaucoma, you said?
It was open-angle glaucoma, ma'am.
What type?
Secondary open-angle glaucoma, ma'am. It was not present at birth.
So, secondary to what?
Probably due to elevated episcleral venous pressure.
Right.
My question would be, how does it justify the title, The Silent Threat of Glaucoma, when you have such a big portwine stain on the face?
Suppose the patient was not evaluated ophthalmologically, sir, and the patient was only given systemic treatment for Sturge-Weber's. The IOP would not have been controlled either through medical or surgical management, and it would have caused further loss of vision.
So now the issue is rather social, that if the child is being exposed to proper screening and proper referral. So that aspect is something that you need to touch upon.
Yes, sir.
So how many points of contact the child has had previously with a pediatrician or a health worker?
With the pediatrician alone, the child had contact, sir, since birth. However, this was the first ophthalmological visit that the child had,
First
sir, at 7
ophthalmological
years of
visit.
age.
So yes, the whole of the immunization cycle has been completed, but the child has not been evaluated ophthalmologically. That is something we as an ophthalmological association have to ponder.
Nice. And
Right.
what about the fundus details? Did you mention?
Yes, ma'am. The fundus in the right eye, the cup disc ratio was 0.8, and there was bipolar neuroretinal rim thinning.
And the
ma'am.
other eye?
Other eye, it was just 0.5 CDR with no
You have
no
slides.
neuroretinal.
You have
Yeah,
slides for it.
Yes,
she did have
She-
slides for that.